Thanks for your cooperation. Today we'll be looking at the knee health in runners, young and old, and we have a great group of speakers on tap. Can I have you each introduce yourselves?
I can kick it off. My name is Mikkel Joachim. I am a research program manager with Badger Athletic Performance at the University of Wisconsin-Madison. Most of my work over the past several years is focused on runners of all ages, but mostly collegiate and adolescent. So I bring definitely a biomechanical flair in particular to this discussion today.
I'll go next. I'm Chris Johnson. I'm a Seattle-based physical therapist and coach. I own and operate Zarin PT and Performance as well as Alchemy Endurance. And I do a lot of clinical education and basically try and keep a lot of athletes in check.
And I am Megan Graham. I am an assistant professor in the Department of Physical Therapy at the University of Kentucky. I just finished up my PhD this last year, and it was primarily focused on biomechanics after ACL reconstruction. So I'm not someone that works with a lot of runners, but I get a lot of people back to running after ACL, which is what I will be covering today.
Great, and I'll introduce Dr. Katie Lucas. She wasn't able to join us today, but Mikkel will be presenting her information. So Dr. Lucas is a assistant professor at Creighton University in Arizona. She is certified sports and orthopedic clinical specialist. Um, and she is a national track and field classifier with the U.S. Olympic and Paralympic Committee. Dr. Lucas graduated from Bellarmine University in '09, graduated from her sports residency program in Cincinnati Children's in 2013, and received a PhD from the University of Kentucky in 2020. So I think that's everybody. So we'll have Chris get started. Thank you.
Great. Let me share my slides here. All right. Um, I want to just first say it's such an honor and privilege to be able to join Megan and Mikkel. They're both razor sharp, and I was blown away by their presentations when I was at CSM. So it's fun to be able to team up with everyone and share my perspective at this point in my career because I'm going to share a lot of not only the research, but my lived experience as well as my work in helping a lot of master's level runners and triathlete enjoy consistent and healthy training across the lifespan. These are the objectives. I'm not going to go through all of these. You'll have access to them in the recording. And I just want to start by paying respect to a lot of people I'm indebted to. This person in the top left is Dr. Freddie Fu. He is a person that single-handedly restored confidence in me as a young athlete when I was told that I would never be able to run again. And then obviously a lot of the folks at University of Delaware, namely Lynn Snyder-Mackler and Dr. Axe, who are my primary mentors, the crew at the Nicholas Institute of Sports Medicine and Athletic Trauma, where Mike Mullaney and Tim Tyler are both connected, obviously the American Academy of Sports Physical Therapy and the APTA. So this is sort of a full circle moment for me, just because here I am talking about knee arthritis and running. And this is essentially what put me into the field of physical therapy. And I may not have appreciated it back then, but yeah, here we are. So this is an Enso that my father-in-law, who's a Japanese calligrapher, designed. And I thought this was a very apt quote. A lot of people attribute this to Mark Twain, but it probably came before him. It's not what we don't know that defeats us, but rather what we know that is not so. And I think that has a lot of salience to the topic of knee osteoarthritis in masters level runners. I've just consulted a couple people this week who told me that, the doc had relayed to them that running is this very injurious activity. And I just sort of scratch my head because when you look at the literature, that's not exactly the case. A couple quotes. I'm always posting quotes on social media. Our patients do not demand that we cure them. They demand that we care for them. And it's more important what you don't do for a patient than what you do. And I think this really applies to managing runners with knee OA because a lot of the times they're offered hyaluronic acid injections, which have a place, I suppose. PRP injections, corticosteroid. Maybe they are offered a knee scope, which is kind of low value care. But the thing that I would say is for a lot of the pure runners that I work with who are in this 40 plus age group, I don't see a lot of knee OA. People coming from other sports, manual labor. Yeah, I'll tend to see maybe a little bit more of an uptick in those demographics. But for the people who've been running for most of their life, I don't see a lot of knee issues. So this is a funny image. I was thinking back to exercise physiology school or undergrad when I took an exercise physiology class. And I had this professor, Dr. Neves, and he walked in. And on the first day of class, he drew a triangle and at the top put 40. And everyone is sort of looking at each other because he didn't say a word. And then he chimed in and said, "This is kind of the beginning of the end." And he was half joking. But today, when we talk about master's level runners, we're talking about individuals 40 plus. Some sports organizations, governing bodies may put that person at or have 35 as a cutoff, but for the most part, when we talk about masters athletes, we're talking about 40 plus. And my friend Mike Studer coined the term geriathlete, which unfortunately is 55 plus. So no offense to anyone who's in that demographic. So I'm originally from Pittsburgh, and I bring that up because I sort of dabbled in a lot of different sports. I played pretty much everything in the book except football because my high school didn't have a football team. And the reason I mention this is because I ended up with a lot of injuries and surgeries. And anytime I would connect with an orthopedic surgeon, they never had good news for me. They would tell me stuff like, "You will never run again," that I have the knees of an 80-year-old, that I'm going to need knee replacements in my mid 30s, which ironically was the first year I raced the Hawaii Ironman and made up over 600 spots on the run, and that I should sprinkle holy water on my knee. So again, very unhelpful things. And if you're telling a younger athlete this, it really elicits a lot of threat and anxiety. We also have people like Dr. Imber, and this video is making its rounds on social media before the start of the new year. And keep in mind, this guy's a plastic surgeon in New York City. And in this video, he said, "Don't run, period. Your knees go, your ankles go, your hip goes. You're going to get shorter from the constant pounding, and to just get on a bike and forget about running." Which is kind of an odd statement, especially because I've almost been in 2 near-death accidents on my bike in New York City, of all places, because I lived there for a little over a decade. So again, you hear all sorts of people sharing their thoughts, many of which are off topic. So these are what we call throwaway comments, and they're pervasive in the medical community, especially in the orthopedic community. So I think everyone who's on this call can attest to the fact that their patients will come in to consult them after they've been told they have bone on bone or they have wear and tear. And this is problematic because it sort of suggests or implies that this person is at the end of the rope or the end of their line. And it's not really setting us up for success in coming alongside and helping these people. So this is a study from J.F. Esculier, who's up in Canada, great researcher. And in this study, they basically showed that 40% of the public and nearly 1 in 10 healthcare professionals either believe or aren't sure if running is detrimental and leads to knee OA, which is crazy to think about. So anytime we're working with someone, we want to make sure that they're working with accurate information or have a plausible narrative. The reason this matters is because people's beliefs will drive their behavior. All right. So if clinicians think that running is injurious, they may advise avoidance. Some runners may stop running. I would say most of the time they're going to disregard your advice. Some people are going to get more deconditioned from pulling back because they're worried about the status of their knee. And this eventually is going to manifest in their symptoms or condition worsening. And this story often becomes self-fulfilling. I talk to so many older athletes and they say, "Oh, I have this bum knee and I can't run anymore." And I always think maybe there's a chance they could if someone really took the time to understand their situation and audit their activity, as well as their lifestyle. So when we talk about OA, there's a great paper from Dr. Collins. It was published in January of 2026 that I would encourage everyone to read that really helps us start to conceptualize OA as more of a systemic disease rather than a single joint or compartment issue. So this is going to be driven by a number of factors: biology, sex, a person's age, their activity level, their metabolic health, as well as any prior injuries or surgeries, whether they've had meniscectomy, ACL reconstruction, or injury. We also, can't ignore alignment. We want to understand psychosocial factors as well as adverse childhood events and what someone's socioeconomic status is, because that can tie in to the presentation of osteoarthritis. So the main thing I want you all to appreciate is that it's reductionist to just say this is a wear and tear type situation. Also, understand that OA is a clinical diagnosis. So we use imaging to support it, but it does not define it. So we make the diagnosis from the presence of load-related joint pain, morning stiffness up to 30 minutes, functional limitations, people having a tough time getting into a deeper squat or sort of sitting as the character is in this emoji, the person's age or risk profile. Obviously, as clinicians, we're going to make a note of specific examination findings such as crepitus, the presence of a knee effusion, what their knee range of motion presents with, as well as imaging. All right. The problem, as we all know, is someone will put up an image and show that medial compartment collapse and say, oh, you're going to need a knee replacement. And the person may not have any symptoms. So again, remember, this is a clinical diagnosis. When we look at the overall prevalence of hip and or knee OA, this is a very heavily referenced paper that was in JOSPT 2017 from Alan Torngelli. When we look at sedentary individuals, we'll see a prevalence of roughly 10.23%. If we look at recreational distance runners, we actually see that drop to 3.5%. And then if we look at high caliber competitive runners, in the sake of this study, these were people who represented their country in competition, we'll actually see a little bit of an uptick in prevalence, and that often goes under discussed when people bring this article up. So as much as we think the knee is this flawed design, it's really a beautiful design, all right? It's built for load. So we have large contact surfaces. We have menisci that are going to help to distribute the force, which is why we want to preserve the menisci at all costs, because those tib-femoral contact forces go through the roof when you start resecting portions of it. And we have cartilage that stiffens with dynamic loading as well as loading rate. So this is an interesting figure that was adapted from one of Dr. Ross Miller's papers, and I would encourage everyone, if they want to take a little bit of a deeper dive on this topic, to read his work. He's done some really interesting papers. And basically what it's showing is that the knee anatomy is such that greater joint loads increase the contact area of the articular surfaces. So if we go from easy breezy jogging or conversation pace running to faster running, yeah, the loads are greater, the rate of loading may be a little bit greater, but it's also those forces are going to be distributed across a broader, greater contact area. So as the load increases, just remember the contact area increases. And this is not too dissimilar relative to snowshoes. So if you think of how a snowshoe works, stress is equal to force divided by area. This is another paper from Ross Miller where he's just showing the cumulative load per mile in terms of compressive knee joint loads and multiples of body weight. So obviously you can see the difference between walking and running. And for the sake of this study, walking was at 3.2 miles per hour and running was right around 7 miles per hour, which is roughly an 8:30 minute per mile pace. So obviously we have to have the capacity or prepare people for these peak loads. But when you look at the cumulative load per mile, there's really no significant difference between walking and running. In the way that he goes on to discuss this in a subsequent paper is looking at this in the context of per unit distance load. So again, peak load significantly greater with running. These forces peak out at mid stance, as I always tell the runners that I work with. This is a mid-stance problem in most cases. Sprinting, different beast. But when we look at the per unit distance load, we again see there's no significant difference between walking and running, right? Because to cover a certain distance, you're going to have to take fewer strides, even though the peak load with each stride is going to be greater. So when we go to help people manage NEOA, assuming they have it, I think of this phrase cruel optimism, which I borrowed from Johann Hari in his book Stolen Focus. And this is kind of how the orthopedic community approaches NEOA. So we take this big, complex, multifaceted problem. We propose a simple, singular solution, such as, oh, we'll go in and do a knee replacement, even though 20% of people still have recalcitrant pain. It sounds hopeful. People often buy in, but it ignores the root causes and doesn't look at this individual in their totality. Right? And as I mentioned, this can fail 20% of people. All right. I have plenty of friends who are starting to undergo knee replacements, and they're having a whole slew of issues subsequent to it. All right. And they thought that it was just going to be a one and done. So remember, cartilage is alive, well, and responsive. So oftentimes people have this notion that it's sort of like a brake pad on your car. And for anyone who consults an orthopedist, there are some good ones, but a lot of them are still working in the biomedical model of you use this, you wear it out, you replace it, rinse and repeat. And what we know is it's a living tissue. You know, if we applied controlled loads, afford adequate recovery time, that our body tends to adapt. All right. There's been a ton of studies looking at MRI changes after running. So I wanted to unpack those a little bit. Most of these studies will look at morphological as well as compositional changes. So morphological changes just means changes in the size and thickness of the articular cartilage. And then compositional changes are more about what's happening inside the cartilage, like fluid movement and tissue hydration. So when we look at these data, what you see are small temporary shifts in cartilage thickness, volume, and composition after a run. And we're usually talking about in the 3 to 5% range. And these are on healthy adults, so keep that in mind. And these changes tend to return to baseline really in hours, not weeks or months. There's one study that's a little bit of an outlier. But for the most part, we see a relatively timely return to baseline, which is, for anyone who's familiar with the double threshold days, this is probably how runners get away with that. They'll do a challenging session in the morning, wait 4 to 6 hours, and then do a subsequent session in the afternoon. Now, if we're talking about people who do have some arthritic changes in the knee joint, I do think affording a longer recovery time is just a good rule of thumb. So we'll circle back to a couple athletes and I'll show you exactly what their training looks like when I map it out over the course of a week. So does running worsen NEOA? If someone does have documented NEOA and their clinical presentation jives with it, the answer is no. So multiple data sets show that running is not associated with worsening knee pain or radiographic progression in adults 50 plus, which is great because we don't need to pull them back from their meaningful activity. And for anyone who runs, trying to get between them and their running is a volatile thing. So the takeaway is recreational running doesn't appear to accelerate OA and can actually be associated with better symptoms. So consistent, tolerable, cyclical movement is really medicine for the joints and has the potential to improve pain. So when we think about knee joint health, it follows this U-shaped distribution in terms of dose. So on one extreme, we have people that are relatively inactive or sedentary. Maybe they have comorbidities. Their metabolic health is not great. Those folks are perhaps at a greater risk for developing NEOA. On the other extreme, we have people that run at a very high level. I have a friend of the family whose son just posted the 7th fastest time in a marathon by a U.S. male, and he peaked out at 150 miles per week in preparation for that marathon over in Japan. Now, think back to that Alan Torngelli study. We see a little bit of an uptick in terms of the prevalence of NEOA in a runner of that caliber, right? For most of the people we're going to be working with, the sweet spot, and hopefully this is what they're following, is just consistent, moderate running or activity. where you're running, say, 3 to 4 times a week on non-consecutive days. Most of that is at a conversation pace, and then blending that with some cross training, whether that's cycling, doing some resistance training. That's kind of the sweet spot that's going to position people for longevity. This is a nice graph that I adapted from Dr. Gessel and Harris. Dr. Harris is at UW or University of Washington. And what it shows is running dose on the x-axis and the risk of developing OA on the y-axis. So when we talk about lower dose running, think less than 25 miles a week. So that's a case where this is going to be beneficial joint loading. All right. This is a good thing for our knees. Now, as we start to ramp up into higher dose running with the extremes of, say, world-class marathoners, that's when we may start tipping the scales where it could lead to joint health issues at the level of the knee. So for most adults that we consult, they have a remarkable past medical history. So we want to really take the time to have a non-rush conversation and really paint a granular picture of who this athlete is in front of us and really understand their past medical history as far as injuries and surgeries. So, if we think of that graph that I just showed on the previous slide, well, if someone has an ACL injury, we're going to probably see a leftward shift in that inflection point, all right? Or if they've had a meniscectomy. If someone has taken care of themselves over the course of their lifetime, perhaps they have favorable genetics, we'll likely see a rightward shift in that inflection point. And the other thing I want to mention is, I don't discourage people who have a high BMI. I don't weigh the athletes I consult, but I never want to discourage someone just because they may be carrying a little bit more weight than is appropriate for them to not run. We don't have good data to show that that's going to lead to injury. I do think that we want to just give that individual a longer runway and maybe start with, 2 to 4 weeks of walking and then have that bleed into a walk run before we work them up to continuous running. We don't want to create obstacles for people to adopt healthy habits as far as movement and lifestyle. So in terms of the Masters runner, the real shift that we're having to contend with is capacity. So when we look at aging trends, we see a loss of ankle power. Paul DeVita did a nice study showing that between the ages of 20 and 80, we can see almost a 50% decrease in concentric ankle power. We see a decrease in rate of force development. We see a shorter step length and an increase in cadence. And that's because people have lost calf capacity, so they can't stride out. And there's probably other soft tissue extensibility changes as well. We'll also see balance decrements. The main thing that we want to zoom in on these folks beyond the knee is what's their calf capacity? How is their calf functioning? So again, when we look at the Masters athlete, Rich Willey and Max Paquette did a great article I would encourage everyone to read. We see a 15.5% lower cross-sectional area, a 6.3 to 9.6% lower plantar flexion strength, and we see a loss in Achilles tendon stiffness, which doesn't bode well for running because running is about elastic recoil. All right. So if we have a tendon that sort of takes on the properties of someone with an Achilles tendinopathy, well, that individual loses stiffness. So you have a less stiff tendon that is going to be less effective transmitting force and more subject to greater strain. All right. Not good with running. So how does this show up clinically? Well, we see Achilles tendinopathy. We see plantar fascia issues. We see calf muscle complex strains that can really be finicky if people go mismanaging those. And remember that, even though most muscle strains occur in two joint muscles and are routinely associated with a traumatic mechanism or a sudden mechanism of injury or onset, soleus strains can be a little bit more innocuous, where someone may report a tightness, which can throw clinicians for a loop or get them barking up the wrong tree. So make sure you just take the time to unpack that and assess them. We'll also see gluteal tendinopathy and hamstring issues. So a lot of these are tissue tolerance limits. The one thing that you definitely want to take the time to do, because it only takes literally 5 seconds, is assess someone for a knee joint effusion. If someone comes to see me for a shoulder complaint, I'm often looking at their knee just to sort of really make sure I understand the moving parts. I'm exaggerating a bit there, but it takes 5 seconds. Don't skip over this because it puts you down two very different lines of clinical reasoning to say, is this an intra-articular issue, whether that's articular cartilage, perhaps there's meniscal pathology, but if you have a knee joint effusion, it's saying things have gotten stirred up intra-articularly versus, say, a knee extensor mechanism issue like a patellar tendinopathy, quad tendinopathy, ITB. So again, these are the grades. This is based off of Lynn Sturgill's 2009 JOSPT article. I'm going to run through these quick to be respectful of everyone's time. But you want to have these committed to memory. And I also have a lot of the patients I work with memorize this, and I teach them to grade their own knee effusion so they can start making decisions on the fly. So I'm promoting autonomy with them. The one thing I want to mention is I'm okay if someone is running with a 1+ or less knee effusion, so long as it stays at that level or improves over the course of the run. But I also want to monitor that patient or get them to self-monitor over the ensuing 12 to 24 hours to make sure that we didn't stir things up, because with a lot of these folks, it's really titrating the dosage. A 3+ is when someone comes in after an ACL reconstruction or an ACL injury where there's just so much fluid, you can't milk it out. So what we're looking at right now is a 2+ effusion. You can see the pocket of swelling right there. As I milk it in the superior patellar pouch, it returns on its own. So that's a master's level female who is basically on the brink of competing in the Olympics several years ago. She had a distal tib fib fracture, and after she had the cast removed, she took her running shoes to the doctor's appointment and ran home 6 miles, and that left lower extremity was never the same after that. I consulted her a few times. That's a 2+ knee effusion. So when I swipe medially, distal to proximal, you'll see that fluid returns, that wave of fluid returns on its own. All right. That's a person that we need to try and get that knee calmed down and create smooth country roads, if you will, as opposed to giving her the green light to keep running. So again, think of a knee effusion as a load gauge when you're working with these people. So if you have a runner come in, a master's level runner, remember, start with the person. Obviously, we're going to examine the knee joint, but really have a non-rushed conversation, all right? Unpack their past medical history. Get a lens into their sporting background. When they were growing up, did they participate or have a rich repertoire of movement, or were these people really just focusing on running and not participating in multi-direction axial loaded sports? If someone, comes from an occupation where there's a lot of manual labor, farming, kneeling, construction workers, you want to understand that too, because they may be at greater risk for knee OA. Get a lens into their physiology. I have everyone I work with walk me through a typical weekday as well as weekend day, because I feel like people are creatures of habit and they have daily routines or rituals. So find out, their sleep, allostatic or life load. How do they approach fueling? How are their relationships with friends and family? We want to understand all these domains before we start swooping in and trying to come up with some mystical, magical fix. And then get a lens into their lived experience. You may not need to unpack all this right off the bat because people may not be so quick to share this stuff because it's personal and private, and they may not even have gotten closure on it yet. But, over time, if you foster alliance and trust, these people may start sharing things about adverse childhood and life events, and then try and get a lens into their thoughts about pain and damage. Right? And understand a lot of people, and I'll bring up a case momentarily. People will say, oh, you have knee OA, and they haven't taken the time to really look at their training and their life loads. So, if you have access to someone's schedule, whether they're recording that on Strava or Training Peaks, look at how they're approaching training intensity distribution. So I always talk about the 80% rule, which is 80% of runners run at 80% intensity 80% of the time, which is why upwards of 80% get injured annually. Look at how close they're stacking intensity. Are they running on non-consecutive days, or are they doing a lot of back-to-back days? Take the time to, at some point, watch them run, which we'll get into momentarily. Are they under the coach who, are they under the auspices of a coach who may be programming for them in a sloppy manner, or who really doesn't understand the implications of how cartilage behaves and hasn't taken the time to examine their knee because they're not licensed to? How do they tolerate downhill running? That's what will get a lot of people in trouble in terms of the knee. And then what's their comprehensive capacity? This is an MR, and it's a lot of word salad, but a guy just sent this to me yesterday who comes from a background of semi-professional soccer. He is always doing home improvement projects where I'm always like, dude, why don't you just hire someone? Because he's very successful. But I think he just likes to revel in some of these home chores. But he has a knee effusion. He has some cartilage loss in the lateral tibial plateau. He has remarkable meniscal pathology. But I asked him, I said, what do you think brought on this setback with your knee? And I said, did you discuss any of this with your doc? And he said, well, last year I continued to do my trail running, but I also added several long, and this is a text literally from him yesterday. I added several long, high altitude mountaineering trips on glaciers. Some of the trips were 10 to 20 hours with up to 10 hours of hiking with a heavy pack. My guess is that that was a major factor. So you want to make sure people understand what landed them into trouble so they don't repeat history. But something like that would definitely bias the load to the knee and could very well account for why he's having ongoing symptoms at this point. The other thing we want to do is take the time to watch someone run to get a lens into their running signature, if you will. Um, Dr. Rich Willey and Irene Davis showed that running is a hierarchical skill. So when you take someone through a treadmill analysis, you can do this from a qualitative standpoint, which I use the S's of treadmill analysis, which I'll get into momentarily because these are easy to explain. And for clinicians who are in a busy outpatient setting, you can be very nimble using this framework. And if you have a little bit more time and you have the tech, which is becoming increasingly more accessible, take the time to do a quantitative analysis, especially if people love sort of delving into the data. So this is going to give you the most comprehensive lens into things. All right. So this is how I approach treadmill analysis. These are the S's. You can just jot these down and circle your responses the next time you take someone through a treadmill analysis. So strike, rear foot, midfoot, or forefoot. You could even say rear foot versus non-rear foot. Step rate, sound, shin angle, symmetry, speed, step width. So if someone has a narrow step width, they're going to expose the lateral aspect of the lower extremity to greater ITB strain and strain rate. And then is there anything remarkable in terms of swing, whether it's during swing of the lower extremity or arm swing? And then just make a note of what shoes people are doing most of their training in. And obviously, we want to reframe this for people. So if someone comes in, you can safely assume that a lot of people think that the knee is a fragile hinge joint. So I always remind people, I say, look, running is normal cyclical load. Our cartilage and our knee is built for this. Consider the whole system. Again, prior injury, their metabolic health. If they have blood work, take the time to sort of get a lens into it. Don't hesitate to refer people out. I work very closely with an RD. Get a lens into their strength and tissue capacity. Take the time to look at their training structure. Try to understand the allostatic or life load that they're dealing with and what's the psychosocial context. And realize that most of the time, load isn't the problem. It's a mismatch between their current capacity and what they're calling on their body to do. So when we go to try and build durable runners and program for joint health and performance, most of these runs are going to be pretty measured, all right? I give runners, even the competitive runners I work with, they get 3 hot or high intensity sessions a week. So one of those would be a long run, one would be, say, some strides, and another one would be some interval work. For masters level athletes, strength is mandatory. This is where most of these athletes can make their greatest gains, all right, especially if they're untrained. Remember that tendons are going to lose stiffness, and we're trying to address the mechanical properties. So I always say tendons love tension. The fundamental cell of a tendon is a tenocyte. It responds to load. So we want to really focus on challenging these tendons, and we kind of need to disturb the system through higher contraction intensity work. Look at cross training as a performance tool. I have so many master's level runners who I have doing a lot of cycling on the non-running days, and that's when I'm often combining the resistance training work with their strength work. And also, people feel so defeated by walk runs. Where I live in Seattle, very rarely do I do a continuous run because it's sort of like San Francisco or my hometown of Pittsburgh, where it's a lot of steep uphills and downhills. So just sort of remind people not to feel defeated if we break up a long run into rather than 90 minutes to 6 by 15 minute bouts. Also understand these are the levers that I tinker with. So everyone I think is very enamored by trying to change someone's running form right now. These are the things that I'm really zoomed in on is training intensity discipline. So, making sure they're not on the gas. I love getting people to run on a treadmill. It's very forgiving. So I'll work that in usually one session a week. I want to be cognizant of their footwear, obviously trying to put some guardrails on someone if their knee is stirred up, where we want to minimize downhill running. Step rate, you just have to see how that runner presents. Schedule, very important. Most of the runners who I'm dealing with, if they have knee OA or their presentation is consistent with that, I want to try and get them running 3 to 4 times a week on non-consecutive days. I feel like if you're running 1 to 2, every session is too much of a stimulus. And if you're running 6 to 7, you're probably tipping the scales. And lastly, just getting a lens into their sleep hygiene. So I thought I would pull in a couple sample training weeks just so you see, when we put pen to paper, what this looks like. This is someone who has a history of long course triathlon, so think Ironman training. And what you'll see is I have them doing 3 bikes and 4 runs. Don't worry about the strength work with this particular individual. And this is just a random snapshot. So I have them do 2 runs on back-to-back days. I make a note to remind them to afford 24 hours just to make sure that we optimize recovery. This is 7.5 minute run at 3 out of 10 on the Foster RPE scale, and then a 42.5 minute run at 3 to 4 out of 10. So what a lot of people think of as zone 2, so just low intensity running. And then on Wednesday, I have them do a little bit of a faster finish, which you'll see here in the graph. After that session, which is going to be a little bit more of a challenging session for them, I'm going to have them go to the bike. All right. And then Friday, again, another measured run. Saturday, I give them a little bit of say in what they're doing on the bike. And then Sunday, a little bit of a longer run when perhaps they have more time in terms of their schedule. Going to the next example, this is someone who is starting to ramp up for a triathlon in fall of 2026. So they weren't doing a ton of running when I connected with them, but you'll see again, I have them cycling 4 days a week. And in this case, I have them doing 3 runs. They tend to ski a little bit more during the wintertime. So as I'm ramping them up, 3 by 11 minute bouts. And I generally try to keep their strength training on a non-running day. He ended up reworking things in this case, but so 3 by 11 minute bouts of running on 1 minute walk. And then I have him do a 15 minute bout, 12.5 minute bout, and then a 10 minute bout on 1 minute walk. And for a triathlon, I'll have someone do just a 15 minute run off the bike, because there was a study from Jay DeSherry and a few of his colleagues that showed that it takes 14 minutes and change after a 30-minute time trial at 80% intensity for your sagittal plane kinematics to normalize. So, for anyone who's working with triathletes, you want to get them doing some running off the bike, and it doesn't need to be too extensive. So, and with this strength training stuff, you'll see very simple things. I'm giving a penguin march with a 25-pound bumper plate overhead. We'll scale this up a little bit. I have him doing a rear foot elevated split squat with 2 dumbbells. Megan just had a great paper on this, talking about the importance of getting someone to advance that shin over the foot to make sure that you're loading the quad in the way that you're hoping. And then I'll get him doing a long lever bridge, and it's cut off here, but a farmer march. And again, just a reminder, really understand someone's ecosystem. When people connect with us in an outpatient setting, The stuff that is in the foreground is my knee's bothering me. I can't run. My knee is swollen, so on and so forth. We want to understand the background because the more we understand the totality or the aerial view of that person's situation, we're going to have a better idea of what levers to pull. Don't always think it's exercise prescription, even though I think titrating the dosage is really important. It may just be, hey, let's get this person, taking a walk over their lunch break, making sure they're hydrating, that they're getting adequate sleep, that if they have, a spousal issue, that, maybe they're taking the time to allocate some energy or attention to that, right? So again, always considering the ecosystem. And as I tell every master's level athlete I work with, in the words of Dan John, don't act your age, but train your age. You can train hard as a master's level athlete, but what I'm appreciating at 47 is I can't be hasty with my decision making around workloads. I can't get away with what I used to, where I can spike my training and there's no repercussions. So there's a great book called Nudge Theory, and I think that's what we do as clinicians. We nudge people along, and that's sort of consistent with how biology operates. And remember that many runners may be resistant to NeoA because of their running and not in spite of it. Think back to what I said from the outset. The people who I consult who primarily focused on running, they don't come in with a lot of knee complaints. It's more the people who were playing sports like soccer or multi-directional sports where they probably had some greater loads going through their knee that may have created some kind of arthritic changes. And a lot of people are probably going through life with arthritic changes and are unaware of them because they're not having symptoms. And this is my role model, Dale. So he was, I think, 87 or 88. He won his age group, I believe, this year. This is Ironman Canada in 2019. And yeah, I mean, he's the epitome of what happens when you have favorable genetics, you take care of yourself, and you embrace running as part of your movement flow or training. And with that, I want to thank everyone, and obviously I'll hang around for some questions.
Thanks, Chris. Um, Chris does need to leave a little early for see a patient, so feel free to type in questions while we're rolling through the presentation here.
Awesome. Okay, I will kick off my talk now. I just want to echo Chris's thoughts. Thank you to the Academy for the invite, both at CSM and today. And the other presenters on this talk have been really fantastic to work with, and it's been a pleasure. So I'm going to tap in for Katie's talk later, which will not do it justice. So you're going to get a little bit from me now and a little bit later. So let's kick it off into anterior knee pain. So not necessarily age group specific, but certainly a high prevalence kind of, across all the runners that we may see. So when we look at anterior knee pain, it primarily refers to patellofemoral pain syndrome, but that's kind of also anterior knee pain is a bit of a catch-all. So it's maybe not as accurate or as appropriate to use that term in the same vein as when we used to call bone stress injuries stress fractures. That just wasn't the best representation. They do account for about 30% of injuries, so they're very prevalent, which is why they get a lot of attention. And they tend to vary by sex. And when I say they, I mean anterior knee pain injuries, not necessarily patellofemoral pain in isolation. So definitely some nuance here, and we're going to dig into some ways to tell these apart and to treat them. But the lion's share of this is patellofemoral pain syndrome. So when we dig into this a little more specifically, a nice sort of consensus statement on patellar tendinopathy or patellofemoral pain syndrome specifically defined it as retro or peripatellar pain aggravated during weight bearing in flexion. So that's really the hallmark in terms of the location of pain and the activities that bring on the symptoms. Is very symptom driven, but other things that you can look for that your patients may report are grinding sensation, tenderness around the patella on palpation, some mild effusion, which Chris did an awesome job explaining the options and how to grade those. And then sort of redundant with weight bearing, but pain during rising or during sitting, during prolonged sitting. So again, very symptom driven and very specific to the location of pain in the knee. When we look at risk factors for patellofemoral pain syndrome, we have a host of non-modifiable risk factors like your patient's age, their height, People have looked at Q angle, so the angle that the pelvis makes relative to the femur, injury history. There's probably some others that I've forgotten off of this list. And then we've started also to focus sort of on these anthropometric measures like weight, body composition. Chris kind of alluded to that in his talk as well. And then we have this catch-all of strength and gait biomechanics. And like I mentioned at the start, I'm a biomechanist by training, so I have to throw the considerations for gait in here. But certainly quadricep muscles, other muscles around the hip have been studied as risk factors for patellofemoral pain syndrome. So when we look at the literature, everything on this slide is sort of what's on the menu to look at for risk factors. But when we look at what we know or how good these risk factors are at identifying people who may go on to get patellofemoral pain syndrome, we don't have very good information. So I would say one thing that we have all agreed on in the running world and more broadly the sports medicine world is that once you have a given injury, you're more likely to sustain it again. So runners with a history of patellofemoral pain syndrome would be more likely to develop that again. But when we look at the other non-modifiable factors, when we look at the anthropometrics, very wouldn't go so far as to say decisive or definitive, but like fairly clear, a growing body of evidence that these things are not very good at telling us who will develop patellofemoral pain syndrome. And when we look over in the strength and gait, I changed all of those to yellow because we have some mixed findings or maybe some mild suggestions that these may be risk factors. So when we kind of break down the running mechanics and think about what would be important to look at, patellofemoral joint contact forces, so the force between your patella and your femur in that joint space, are up to 10 times your body weight during running. So the best evidence we have so far for looking at running biomechanics are things that might increase this joint contact force. So when we look at our running mechanics in runners who currently have patellofemoral pain syndrome, so these may be compensatory mechanics as opposed to risk factor mechanics, we see reduced pelvis range of motion in the frontal plane, increased knee range of motion in the frontal plane, and decreased knee range of motion in the sagittal plane. So they tend to be a little more stiff, not stiff in the biomechanical sense, but like you looking at the runner, they don't feel like they're absorbing force as well in the sagittal plane. And some of that manifests itself in more frontal plane motion, specifically at the knee joint. When we look at mechanics in healthy runners that have been modeled to increase patellofemoral joint contact forces, we see things like increased adduction excursion, increased abduction angular impulses, and a slower step rate. Important to note that to actually appropriately measure patellofemoral contact forces, that would be a fairly invasive research endeavor. So again, these are just things that have been modeled through our biomechanical models and measuring muscle activity and different joint biomechanics that we think should increase these joint contact forces. So again, how these relate to the development of patellofemoral pain syndrome, we're a little unclear. These are just things that we think may be good to screen for and maybe have some association if your runner is reporting this patellofemoral pain. So when we go on to look at management strategies, there's a really nice systematic review, a clinical practice guideline that sort of highlights the evidence for a variety of things that are commonly used in clinical practice. And they bucketed things into strength and manual therapy, taping and bracing, and gait retraining. So I color coded the evidence. So green, we have good evidence in favor of using that approach. Yellow, we have weak evidence in favor of it. And red is we have good evidence to not use that approach. So I'll just quickly kind of run through these. So when you look at increasing posterior lateral hip strength or knee strength, so quadriceps muscles primarily, good evidence that increasing strength can help alleviate patellofemoral pain syndrome. The evidence is kind of out on BFR as blood flow restriction as an approach. I think we probably just don't have enough evidence. It certainly wouldn't hurt, but is it the best return on the investment for your clinic time? Hard to say. And then mobilization about the knee is definitely not something that has been shown to manage pain related to patellofemoral pain very well. When we look at taping and bracing, patellar taping and orthoses are great. They're great in the short term to get symptoms to calm down, and then you should work to wean your patient out of those and kind of strengthen the system to support a good movement pattern. But using braces, sleeve straps, definitely not recommended based on the current evidence. And then when we look at gait retraining, I put these as weak evidence for reducing rear foot strike or increasing cadence. Those tend to go together. If you increase your cadence, there's usually a cascade of other biomechanical changes when you're running. We don't, again, have the best evidence to say if you do this gait retraining, that will definitely resolve your patellofemoral pain. But increasing cadence tends to reduce load at the knee, should theoretically reduce joint contact forces. So that can be a management strategy only if your patient tolerates it well and only if it's paired with appropriate strength training to support that new running pattern. So we're going to move into patellar tendinopathy, which is kind of the other main knee injury, anterior knee injury that we see. I'm going to go through things in the same way and then sort of compare and contrast the two injuries at the end. So to make a patellar tendinopathy diagnosis, and very specifically, tendinopathy is the best term. Tendinosis, tendinitis, those are sort of outdated terms as well. So we're looking for pain or stiffness below the patella that's made worse with jumping, running, stairs, deep squatting, weighted flexion, anything like that. And pain with palpation. I personally have had some pretty bad patellar tendinopathy in the past, and I can tell you that, it hurt all the time. It hurt when I was sleeping, and it's particularly hurt to palpate right on that tendon. So that can be kind of a telltale sign. Um, Interestingly, this tends to be more common in males. So the fact that I got it was bucking the system a bit. And it does typically present in that proximal third of the tendon. That's not to say you can't get tendinopathy more distally, but it does really tend to be up where the tendon's a bit wider, and is probably getting more of the force transmitted through it. And there's a lot of other sort of emerging evidence related to how the patellar tendon does really have different regions, and the composition of the tendon fibers within those regions can vary quite considerably. And so I think we're working on our understanding of why the patellar or the proximal third would disproportionately be impacted when really everything should theoretically kind of be moving together. So same thing, let's kind of unpack these risk factors for patellar tendinopathy. We have all these anthropometrics. Some are modifiable, some are not. A lot of training factors come into play with tendinopathies, such as running volume, how much they're jumping, how much strength training you're doing, what intensity or running speed are you running at. And then always with me, the biomechanics, right? So previously we've looked at ankle dorsiflexion range of motion. We've looked at just general gait mechanics in general, and then knee extension range of motion as well. So I would say we have more evidence that more variables may be in play with patellar tendinopathy, but we really don't have any better evidence of risk factors relative to patellofemoral pain syndrome. So in terms of anthropometric, this is where weight can come into play. And I think really the main mechanism, which Chris again alluded to, is the heavier a runner is, inherently there will be more load, more force on their joints. That's not to say that we can't manage that and kind of work on mechanics that would support a healthier knee. But that is a very legitimate factor to consider in patellar tendinopathy. When you look at pathology, again, you can use ultrasound imaging. I'll talk about that a little bit in a few slides, but I wouldn't say that we have good evidence to say if this is how you look on imaging, you will for sure become symptomatic. And I'll share some really interesting data about the prevalence of asymptomatic tendinopathies. In terms of training, moderate evidence about how much you're running or jumping, how fast you're running. But we don't have a blanket recommendation. We haven't figured out, like, if you keep your volume changes under X or under Y, then that would be protective. Gait mechanics, nothing is really associated thus far based on our current understanding, but there may be some joint range of motion contributions if you have limited ankle dorsiflexion or knee extension range of motion. Okay. So ultrasound imaging, this is where our group's done a lot of work recently, and it's a pretty exciting emerging field because it's becoming more and more accessible. Ultrasound is getting a lot cheaper, a lot faster, and also a lot smaller. You can get units that just connect to an iPad or your phone, which is great. So the things that we tend to look for on ultrasound is tendon thickening, if there's blood flow via Doppler, if you can see calcification throughout the tendon, so those are like kind of concentrated pockets of dense tissue, or hypoechoic tissue. And hopefully this shows up well for everyone on your screens, where you can see to the right of this yellow box, everything is pretty striated, bright white and dark black. And then what I've highlighted is sort of a dimmer, less organized section of the tendon, and that's where it's hypoechoic, to suggest that there's some tendon disorganization there. When we look at quantitative imaging, you can look at things like shear wave speed, and this measures how quickly a wave of ultrasound waves, that wasn't maybe the best way to explain that, but basically when they send the ultrasound waves through the tissue, how quickly are they able to move through the tissue? The thought being that a more organized tendon with more parallel fibers would facilitate faster wave speeds. I will say anecdotally, we are sort of seeing the opposite, that we're actually seeing some higher wave speeds in pathological tendons. So, very unclear what direction we need to head with that, but it's certainly an emerging field, and a lot of new research is coming out using shear wave speed for tendinopathy. And you'll see this red here is where there's a lot slower wave speeds. And so, I should say these are not from the same athlete. But we would think that this red, more proximal region is perhaps where some patellar tendon issues may pop up. So like I mentioned, pathology is often present in the absence of symptoms. So this is some unpublished data from our runners at UW-Madison. We've scanned 18 females and 14 males, so 36 and 28 limbs respectively, and almost no one is reporting pain on a given limb. So 2 out of whatever that is, 64 limbs were reporting patellar tendon pain. But when we look at the key metrics from ultrasound that I mentioned on the last slide, we see a very high prevalence, particularly in males, of hypoechoic tissue and blood flow, and also a surprising amount of blood flow in females. And tendons should typically be avascular when they're in a healthy state. So all this to say, if you were using ultrasound in your clinic practice or your research practice, there's a high probability that you're going to find some pathology, but until the person becomes symptomatic, it's not diagnosed as actually having patellar tendinopathy. So we really need that pain component to push us over the edge and sort of suggest that maybe we need to do some management or treatment strategies. Ooh. So in terms of management strategies, there's an article out a couple years ago in JAT that I think lays out a really fantastic framework. So you start with symptom and load management through cross-training, lower impact activities, anything to get the tendon to calm down and start to reduce pain. We start to move into a recovery mode where you reintroduce impact at a submaximal level. So this could be slower running, this could be squatting instead of jumping, just submaximal jumping, things like that. Start to rebuild their capacity. So you slowly want to return to maximum effort impact, very gradually and always mitigated by pain. And then once we can get up to the prior level of impact, be that running intensity or amount of jumping, then reintroduce more volume, and then start jockeying between adding volume and adding intensity. The caveat again is that all of this has to be guided using pain progression. So if in the 24 hours, I would say immediately following up to the 24 hours following some rehab session or training session, if their pain stays below a 3, you're good to progress them. If they maybe are like a 5 right afterwards, but kind of improve to a 3 or lower within the day following, you can probably progress them, but keep an eye on it. Make sure that we're not consistently getting my pain is 5 out of 10 or higher. If you get a 5 out of 10, certainly throughout the day following your activity, you need to go back a step. We've gone too far, the tendon's getting irritated again. So just be very mindful of where your patient is having symptoms provoked and what activities we're doing that, and then always be prepared to sort of cycle through this process. It may not be a straight line as I showed here. Okay, so if we run through a comparison to kind of bring this home, patellofemoral pain and patellar tendinopathy have different symptoms, different locations in the knee. Women are more likely to have patellofemoral pain syndrome. Men are more likely to have patellar tendinopathy. When we look at risk factors, patellofemoral pain is a little more running mechanic driven, a little bit more strength driven. Tendinopathies tend to be more related to training errors and just overall load to the tendon. Limited evidence for retraining in both of them, though I will always sort of be a proponent of exploring or trialing out increased cadence. Typically, there's not a downside, provided that your patient tolerates it well, and that you're just sprinkling it in as a way to alleviate symptoms or help support their training goals. And then management strategies, again, patellofemoral pain, more strength. You can use taping or orthoses in the early days, but try to wean out of it. Consider gait retraining. Patellar tendinopathy is all about symptom reduction and then progressive loading and making sure that you prepare that tendon to get the load that is required to do the activities that your patient would prefer to get back to. So that is it for me. Happy to monitor for questions towards the end, and I will pass it off to Megan.
I'm here. Okay, let's get mine pulled up. Okay, can you see that? We're good? Okay. All right, we are going to pivot to talking about progressing back to running after ACL reconstruction. So the objectives for this talk are to first recognize common gait deviations that occur after ACL reconstructions, talk a little bit about how quadricep strength and other potentially modifiable factors contribute to these gait deviations, and then finish out with some potential, I'll use evidence-based loosely interventions to help mitigate or reduce these gait deviations. Let me move my face out of the way. Hold on, I'm covering up my own PowerPoint. Okay, so typically after ACL reconstruction, I mean, if you've treated an ACL, like the first thing they ask you when they get to clinic is when they can start running again, which is ironic because the second they start running again, they hate it. But it is a big milestone, and it's something that patients really cling to feel like they're getting back to normal and they're regaining that function, especially when you're working with those high school age athletes. Typically, we're clearing people to begin running around 12 weeks. However, we'll talk about time as maybe not the best criteria to be using. But we see that even after waiting for time or looking at these other variables that may suggest somebody's ready to start running, that individuals have persistent impairments with running, and these carry over to other athletic tasks. So if you're asymmetrical with running, when we think about getting back to cutting and pivoting or sports, obviously those are higher demand tasks. Those asymmetries are going to be present as well, if not more pronounced than we're seeing with straight line running. And so why do we care about this? We see that these running gait deviations can persist for up to 5 years after ACL reconstruction. And this is important for a few reasons. One is that this underloading pattern, which we'll observe here shortly, has been linked to an increased risk of post-traumatic knee osteoarthritis development. And additionally, individuals who offload more have lower bone mineral density in the distal femur. So it's not just a performance issue, it's actually a knee health issue. So understanding how we can recognize these types of deviations and potentially try to intervene is going to be really important for the long-term health of our patients' knees. So we're going to do this in a little bit of a case study type method here. We are going to start with, this is a real patient. This is one of my former patients who I shall not name. We'll call her Emily. She is a high school dancer, so she's a modern dancer. She's about 5 months post-op with a bone patellar tendon bone graft. This is from one of her data collections. So this is a slow-mo video of her running. And we're going to break down what is happening at her knee, but it doesn't take a biomechanist to see that that knee closest to us looks a lot stiffer and less supple compared to the other side. So that knee closest to us is her ACL leg. And so I'm going to show you a little bit of behind the scenes of what we're actually looking at from a research standpoint. And so you saw back there, she had cameras around her, she had little dots on her. When we look at research regarding running biomechanics, this is generally done through 3D motion capture. So once we process that data, this is what it looks like. I'm going to try to slow this down if I can. Of course I can't. We'll just let it loop. But essentially, it looks like a headless, armless skeleton running on the treadmill. Those blue lines are the ground reaction forces. So she's running on a treadmill that has force plates embedded underneath. And using that information, we can get a variety of data. We can get joint angles, so kinematics. We can get joint forces, moments, so kinetics. And then we can also get the ground reaction force curves. And we're going to take a look at all of those. When we look at a summary of differences in kinematics and kinetics long-term during running after ACL, those are great recent systematic review that I'm going to draw on and then compare and contrast Emily's data too. And so when we look at kinematics, again, kinematics is our joint angles. So there's no force data involved. This is just our joint angles. When we look at knee flexion angle at initial contact, there's moderate evidence to show that there are no differences in knee flexion angle at initial contact between ACL involved and uninvolved limbs. However, there is strong evidence that peak knee flexion angle in stance phase is reduced on the ACL limb compared to the contralateral during both short term, so if we think of where Emily is post-op, and long term, so thinking a year or longer out. And so when we look at her actual data, so I pulled out her stance phase. I tried to erase the uninvolved or the opposite leg. So we see here that the ACL leg is in pink. So this is her in mid stance, and then her uninvolved leg here. And so we can see that that ACL limb is not going into nearly as much knee flexion in mid stance as her uninvolved side. And when we look at what this actually looks like from an entire stance phase, where that 0% is initial contact all the way through toe off at 100%, the ACL limb is in that dashed pink, and then the uninvolved is in the green. We see similar to the systematic review and what they found, we don't see real significant differences in knee flexion angle at initial contact. However, when we get to mid stance, we see that there is a 14-degree difference in knee flexion angle at mid stance. So pretty notable difference, and I'm sure you guys could see it if I replay that video now. But we see a much kind of stiffer kneed gait on the ACL limb compared to the contralateral. When we start to look at kinetics, so kinetics, we're going to talk about just the ground reaction forces, and then we're also going to talk about knee moments. So just looking at ground reaction force, there's strong evidence that there's no difference in ACL reconstructed versus controls or contralaterals at mid and long-term follow-ups. And then for peak internal knee extension moments, which we'll talk or review what that is here shortly, there is strong evidence. So probably the largest differences we see between limbs are in these peak internal knee extension moments for both short and long term. And we see this similarly with our subjects as well. From the time they start running to the time that they're discharged up to a year, we still see those big differences in knee extension moments. And so starting with vertical ground reaction force. So if you guys aren't familiar, briefly, that ground reaction force starts the moment your heel hits the force plate. And we see this initial impact peak. So we can kind of surmise here with that impact peak that Miss Emily is a heel striker. So whenever someone has a heel strike, we see this little impact peak, followed by this dip, which is essentially our foot becoming flat on the force plate. If someone's a forefoot striker, this is just going to look like a nice round curve. But we don't see real differences in the impact peak. It is more pronounced on the uninvolved side. But if we actually look at the peak ground reaction forces, decently symmetrical, a little bit lower on the ACL side, but not nearly as pronounced as what we're seeing for knee flexion angle and moment. When we look at moment, so moment is essentially how hard your knee extensors are working to keep your knee from bending. And so the knee flexion angle is just looking at the joint range of motion. The knee extension moment is taking into account the ground reaction force, how big it is, and how far it is from your knee joint center. And so this little yellow line here I plotted, that is our moment arm. So how far the ground reaction force is from our knee. We see that the moment arm on the ACL limb is almost non-existent. It is so small. And what that's doing is reducing the amount of force that the knee extensors are having to generate during mid stance. And that is typically a compensation for quad weakness. So when we actually plot the knee extensor moment, when it's below 0, that means it is a knee flexor moment. So the hamstrings are working. When it gets above 0, that means it's the quads are working. So it's basically the ground reaction force is either in front of or behind the knee. And we see that at mid stance, we have a significant difference in the extensor moment between limbs, less than half. And she's 5 months post-op. So the difference in the amount of work that that quad is doing side to side is large. And this is that sort of underloading that I was talking about that has been linked to post-traumatic osteoarthritis and lower bone mineral density. Knees like that contact force, and chronic underloading can cause joint issues. So I know what you're thinking. I don't have visual 3D. I don't have 3D motion capture capabilities. How am I going to measure this? The nice thing is this type of technology is becoming more and more accessible for clinicians that do not need to have a full dedicated lab space to make these analyses happen. There's a couple options, which we're not going to get too in the weeds in. Oh, thank God the sound didn't play. So Canovia is one option where you can take just a regular camera and use this software post hoc on the computer to calculate joint angles. The software is free. We do use this during our runners clinic evaluations. And then there's also OpenCap for people that want to get a little bit more in the weeds on the actual joint kinematics. OpenCap is a free software. Let me zoom in here. And it takes some setup, but if you have a static treadmill, you can actually get this software to kind of recreate these similarly to what we're doing in the 3D motion capture and get just joint angles. So right now, to my knowledge, we cannot get kinetics with this because we don't have the force data. I believe they're working on modeling that. But we can get joint angles, which is super exciting. And I guarantee you, if you showed a runner this, they would flip out and think this was the coolest thing ever. So if you do have time for dedicated running assessments, this software is free and accessible. You just need a couple tripods, some iPads or iPhones to take various angles. But we'd play around with this in lab and it's pretty sweet. And so just using kinematics, this is a recent study by Rich Willey's group that found that peak knee flexion angle symmetry demonstrated strong accuracy in estimating patellofemoral joint and tibiofemoral joint reaction force symmetry and helped to identify patients with clinically significant asymmetry. I know that was hard to read, but essentially, if you see that peak knee flexion angles during mid stance are different, you can be very sure that the joint reaction forces are different. So if you're seeing visually kinematic differences, those kinetic differences exist and are likely more pronounced than you're seeing kinematically. So if you don't have the software or access to a biomechanics lab, just assessing kinematics is a fantastic start and you can get a lot of information from that. So contributing factors, I'm going to break this up into both strength and function. So the big thing that we talk about with ACL is quad strength. We see that quad strength is persistently weak, can also be weak for years. And when we talk about the amount of work that the knee extensors have to do during mid stance, if you have persistent weakness, you are always going to have asymmetrical running mechanics, especially as we start to increase speed and increase the amount of work that those knee extensors have to do. And so when we talk about quad strength, we can talk about two different things. We can talk about symmetry, so how symmetrical is your strength between limbs, and normalized strength. How strong are you for your body mass? And so there's been several studies looking at, are there minimum thresholds that people need to hit from both a strength and normalized strength perspective to demonstrate either somewhat symmetrical running mechanics or be able to successfully complete a return to run program, which that could be defined as several things, but most often, can they complete it without increased pain or swelling, which is always the goal that we have as PTs when people start running. And so the cutoffs that are have been kind of widely talked about, a lot of protocols say 80%. If I held a BTB to start running until they were 80%, they would probably quit coming to see me because that will not happen until they're 9-10 months post-op. I do not think that we need to hold people that long. There's a decent body of literature showing that 60 to 65-ish% limb symmetry index is likely strong enough to be able to tolerate a return to run progression. And that seems more feasible to kind of patient preference and goals as well, where that typically hits around that 3 to 4 month mark. For normalized strength, when you're looking at literature on this, it's really important that you're looking at the mode of testing that's being done. When we talk about isometric testing, you can produce the most amount of force during an isometric contraction. So for isometric testing, somewhere around 1.7 newton meters per kilogram. For isokinetic testing, that's going to drop to 1.5 to 1.6. So make sure you're not holding people to a standard that is done isometric when you're testing isokinetic. Side rant. And so when we look at Miss Emily, we're going to look at what her metrics were for these two things. Did she meet the minimum thresholds? So her limb symmetry index for her quad strength was 76%, which is actually pretty solid. And then her normalized strength on her ACL side was 2.05 newton meters per kilogram, isometrically. So she hit both buckets for that. So we feel good that is likely not her strength that is making her running mechanics look really bad. So then we need to start to investigate further into what we think might be causing her to run with such a stiff gait. And then we move into knee function. And so the word function is really broad, but I needed to break this up into two categories. So that's where we are. Subjective knee function. So the IKDC is something that is commonly used. Similar studies have looked at subjective knee function as a metric to predict readiness to return to run with a cutoff threshold of 64. And then another thing to consider here is knee effusion. You could have good strength, but you have either reactive or persistent knee effusion or anterior knee pain that is causing you to want to avoid that knee during gait. So when we look at her IKDC score, she's, ish, she's there. I'm going to give her a yellow check mark. That's when I might dive into the questionnaire and look at what is she saying is bothering her. Is it anterior knee pain? Is it clicking and popping? Are there things that we can address clinically to help increase her perception of her knee function? And then her knee effusion, she does have trace swelling. So some intervention strategies. We're going to break this up into two parts. One are running specific interventions, and then the other are more impairment-based interventions. So as far as interventions for improving running, I'm going to be honest, there's not a lot from an evidence standpoint. So we're going to go with what has been discussed with hopes that future research can give us better ideas of how to fix this. So cadence manipulation, if you're in the running world, I know that you've heard of cadence manipulation, and then real-time biofeedback on that cadence manipulation. I know there are some labs right now doing real-time biofeedback during running. We are not going to talk about that today, but that is another potential avenue, side note, but beyond the scope of this talk. So for cadence manipulation, typically we think about trying to increase individuals' cadences, especially if they're having knee pain. We're trying to decrease stride length and get them to turn over quicker. However, we see that in ACL populations, this doesn't reduce asymmetries. So it actually makes them load their knee less. So when we start to transition to that more mid or forefoot strike from a rear foot, we take some of that load off the knee, which if somebody's having a reactive knee or they're having a lot of anterior knee pain, that might be a good thing in the short term. But when we talk about how knee underloading in general can lead to long-term issues, this would not solely be solved by increasing cadence. We're actually reducing the amount of load through the knee during that. So that may not be our best intervention in an ACL population. There is some evidence potentially to suggest, I say some evidence and then it says no evidence, there is a theoretical concept that we might want to slow cadence. This seems counterintuitive to most people who are interested, but here we can actually increase knee loading. Now, if somebody has a reactive knee and they're not able to tolerate this, this would not be something that if we're trying to force use or loading, this can be a strategy short term to try to get somebody to load more through their ACL side. And then cadence biofeedback, if we're trying to slow cadence or alter cadence, we can use biofeedback like the watch to give an auditory or vibratory stimulus to help maintain that cadence. And when we're working on running retraining, it's important that you're doing this in a really controlled setting, typically on the treadmill or in a track if you're somebody who's very familiar with running and can maintain a consistent pace. But we want to make sure that we're not increasing or decreasing cadence while also altering speed. Okay, impairment based. So quadricep strengthening. We talked a lot about the quads, which can't have an ACL talk without talking about the quads. Plyometric progressions, and then finally impairment resolution. So looking at range of motion, swelling, etc. For quad strengthening, I see a lot of people who, when they start running, they really cut back on the strength training that's being done in rehab. You really do not want to stop strength training when you start running or introducing plyometrics. If you're only at 60% for your strength, it is critical that you continue to work on strength and hypertrophy during this phase. especially now that we're starting to expend more calories. Running is going to be more of a catabolic stimulus as opposed to an anabolic stimulus. So it's important that we're trying to mitigate any loss of muscle because we still have a long mountain to climb for strength. And so for knee extensions, I love to do lengthened partials, especially if somebody is having patellofemoral pain. We can lift heavier without getting that irritation of going all the way up through end range. And we know that hypertrophy is maximized when we're training at long muscle lengths. So we use a lot of lengthened partials. You can see there he's like kicking to the box. So that's his end point, and he's going all the way back into maximal knee flexion every repetition. I'm working on eccentric loading. That mid stance phase is an eccentric quad contraction. So making sure that we are exposing the quads to heavy eccentric load as well. And then working in a variety of load and repetition ranges. We do a lot of super high rep to fatigue. We do like heavy and slow repetitions as well. So making sure that you're giving that muscle a lot of different stimuli to help keep it progressing in the right direction. Split squats. I'm almost sick of talking about split squats at this point, but it's important when you're doing closed chain exercises, especially in preparation or during running, that you are limiting movement options for people. If they're offloading during running, they're offloading during exercises. This is a hell of a lot more demand on the knee than running. So it's important that we're getting that knee used to tolerating load in a weight-bearing position, because if they cannot tolerate it in a static position like this, when you start to add in a dynamic system and give them more degrees of freedom, they're going to take the path of least resistance. So when I do split squats, I like to constrain the trunk so they can't offload onto that back leg. We focus on depth, driving that shin over the toe, knees over toes, please, knees over toes, and we load them. So these are really heavy. That is not a fake face. These people are struggling. It should be hard. For plyometric training, with Emily, she didn't have a ton of issues, but she just had a really difficult time during plyometric tasks being able to bend her knee in a dynamic manner. So she could do our closed chain task, but when we added that speed component, sort of like with running, she really struggled. So we took a step back and really focused on more targeted plyometrics to get her comfortable bending that knee under load. And so the framework that I like to use, which I'll skip to, is we start with what I call a load or an explode. So we're working on one of these. We're either doing a drop landing, so that's our loading, and we're focusing on the landing, or we're working on the explode portion, so like a box jump. So we've put this into two different buckets and we're working on them separately. Once they're able to do those pieces separately and able to bend the knee, I start to add things together. So a load and an explode, which would be a counter movement jump, a drop jump to a box jump. So we're combining a load and an explode. And then we can add more complexity to it. I hate saying this again, a load, explode, load. So drop vertical jumps, we're having to, what she's doing here, load, explode, load. And then working on initially that intentionally soft landing where we're going through a lot of knee excursion. And then as we start to get stronger, working on an intentionally stiff knee instead of a pathologically stiff knee. And those are two different things. So it's important to have really intentional progression of that plyometric work. And then last but not least, impairment resolution. These are the boring parts of PT that get overlooked, but making sure that your patient has full terminal knee extension. When people start running and doing dynamic stuff, at times they tend to lose it. So making sure that you're checking that regularly and that they have full passive knee extension. Additionally, that they have full, say, quad activation. We do NMES for upwards of 6+ months with our patients. And then monitoring swelling. Chris talked about the stroke test. If you're starting a new activity with a patient, monitoring swelling and making sure that that patient doesn't need to be stalled or regressed. So if someone has a static kind of trace or +1 swelling, maybe I'm okay with it. But if that knee is swelling or they're getting more knee pain as you're starting to introduce running, then you need to take a step back. So, clinical takeaways, we know that running gait deviations persist long term and are linked to post-traumatic osteoarthritis and loss of distal femur bone mineral density. That these 2D gait assessments can be used to help identify kinematic impairments that can be indicative of those joint loading issues. That quad strength and knee function should always be objectively assessed before and during a return to run program and after. And that research on successful interventions is unfortunately lacking, but considering potentially slowing running cadence, doing really intentional and targeted plyometric training, and progressing your quad strengthening, and also being very intentional with that. So, on to not Katie. Thank you, Mikkel.
Yeah. Okay. I know we're a little bit over on time. I'm going to fly through Katie's slides for two reasons. One, I will not be able to do them justice. And two, I just want to respect everyone's evening and leave some time for questions. So let's dive right in. So Katie has particular expertise in adolescent running injuries. And as I mentioned before, I've done some work in this area as well. So hopefully I can field questions. And I think both of us would be happy to have people reach out to us after the fact as well if you have more specific inquiries. So let's go. Learning objectives, great. Okay, so there's kind of this catchphrase in the world of adolescent running and adolescent sports that kids are not small adults. We can't just take what we've learned in the adult population and drop it straight onto kids. And there's a lot of reasons for that. And if we kind of look at the age spectrum that Katie has outlined for us here, this adolescent phase, there are so many body systems developing in terms of your bones growing, your muscle mass changing, your hormones are changing. And then there's also just a very different environment that adolescents exist in terms of priorities and motivations and pressures that adults don't have in the same way or certainly to the same degree. So when we look at the developmental model, there's kind of these 5 stages that are well defined that start with discovering, learning, playing. I have a 7-month-old, so we're in it. We're learning to crawl, which is very exciting. And then it kind of progresses all the way up to thriving and then actually being able to mentor people in the same skills. And when we look at the age range that tends to encompass adolescence, so we think like, preteen through high school, most of the stages in this model happen during that age range. So, we have a little bit in stage 1, a lifetime in stage 5, but in this sort of like decade, we're flying through 2 to 3 stages. And so there's just so much changing, and how that can impact running and injuries can be really pronounced in this age group. So I apologize. There's a video in this PDF, and Katie said she's happy for us to send these around. The video is just of some girls just running for fun and how that looks like a very different movement pattern compared to our more seasoned or adult runners. So starting around age 10, younger for girls than boys, we start growing height, gaining mass, our bone lengths are changing, our nervous systems are changing, our nutritional needs are changing. And again, like I alluded to, there's just a lot of sort of social, psychosocial, interpersonal things that are changing. So we really want to encourage kids just to have fun at this stage and not really be so worried about the quality of movement. And when we look at what the typical injury rates are in high school runners specifically, we have girls on the outside and boys on the inside. Bone stress injuries, particularly in the tibia, can be really pronounced. Patellofemoral pain, like I alluded to, can be very pronounced. We see a lot of just sprained ankles, Achilles tendonitis, tendinopathy, so a wide variety of injuries that are more prevalent in this age group compared to older runners. I think if Chris, for example, were to put up a comparable slide, the proportions and even the types of injuries that are on this would be very different in the masters runner compared to the adolescent runner. And so when we look at kind of the injuries throughout the lifespan, the 2 that we want to hone in on for adolescents in particular are Osgood-Schlatter and SLJ syndrome. So when we look at Osgood-Schlatter, it's very common in this adolescent age range. You have pain right on the tibial tuberosity because your patellar tendon has sort of avulsed it from the bone. So it's a traction injury. And you tend to have pain and swelling. And then like patellar tendinopathy that I spoke on earlier, there's a lot of pain with kind of quad focused activities or anything with knee flexion. So running, jumping, squatting. So it's not, the symptoms aren't specific to running, but they kind of come up through a lot of things that these athletes are doing. And when we look at SLJ syndrome, it shies ever so slightly a little bit younger, so more 10 to 14 instead of 10 to 16. The pain will be more proximal, so even more proximal than patellar tendinopathy. It's really like on that inferior pole of the patella. So similarly to a traction injury of the tibia with Osgood-Schlatter, it's a traction injury of the patella, but the symptoms are quite similar. So beyond the location of pain, the way that you would diagnose these or the way that they present would be quite similar in this age range. So for rehab considerations, muscle flexibility, I think because there's so much growth, we need to make sure that the muscles are at a length that can support that growth of bone during this phase. More proximal stability, so anything to ensure that core strength, hip strength, I would venture to guess some pelvic floor strength would contribute to improvements with both of these conditions. Always emphasizing proper form. So while Megan really advocated for knee over toes for ACL loading, that might sort of provoke some of the symptoms with these two conditions in an adolescent runner. And then always, always, always appropriate fueling and appropriate activity dosage. I think it's really easy for our adolescent athletes and runners to get a little out of balance. School days can be tough to fuel appropriately, particularly if you are competing on your cross country teams or putting on more miles. And then just being really mindful with when they're introducing activity that it's not this like 0 to 60 because they did nothing all summer and then cross country started in the fall and now they're running 20 miles a week or 30 miles a week. So just being really cognizant of what framework you're putting around that runner so that they can be successful and hopefully minimize injury. In terms of gait retraining, I remember from our prior talk with Katie, she sort of emphasized moving from an intrinsic to an extrinsic focus. And so intrinsic would be, where do you feel like your foot's landing? They may be looking down at their feet. They may be having some audible cues from a metronome and just really moving them towards something that they could take with them outside. But I think in this age group in particular, you really need to start with something very tangible and very specific, where maybe you could go straight to just monitoring on a watch or using more external cues. With an older runner, you could kind of jump a few steps ahead in their gait retraining. Kind of alluded to training considerations already. There's just so much more fluctuation with adolescents between school days and holidays and school days and weekends. Just being in school for 9 months a year and then what summer looks like. And so really being cognizant of limiting too much too soon, making sure that they're not only running, that they're getting some multi-directional activity exposure, certainly some rest days throughout the year, and then dosing related to, perhaps if you have either a kid or the runner in front of you who's not sleeping very well, maybe we back off of training and trying to sort of get all these things coordinated in conjunction with each other. It's hard. I mean, this is a long list of things to be considered of, and so coordinating all of it can be challenging, but at least being cognizant, and if you have a patient in front of you, asking some questions about how are you sleeping, how is school going, is this a busy time with midterms, might help you better support their whole health and alleviate some of their running injuries, particularly at the knee when we know that these might be related to more like training errors and things like that. So there are her references. I know she had this very nice anecdote that I'll just leave up if people want to read it, but otherwise I will end it there and hopefully we can field a few questions.
You guys, that was fantastic. Hopefully we have some questions here. I know Chris talks for a long time, which I'm thankful for. But I think some people may have jumped ship already. So
No problem. Yeah, we appreciate everyone sticking with us.
Megan, I have a quick question for you.
Yep.
Um, do you ever manipulate the hip flexion angle with your lengthened quads? Like
Um,
longer?
if sometimes if they are a quad tendon, but not typically otherwise.
Gotcha. And then Mikkel, I have a quick question for you. With the work that you've started to do with the ultrasound imaging,
Yeah.
what threshold were you guys using for hypoechoic and then for what's considered thick?
Yeah. Fairly subjective, I would say.
Okay.
So we definitely don't have um, any sort of thresholding for hypoechoic. I think we found as you get reps, it just becomes very clear to recognize that pattern of tendon is different from the surrounding tendon. In terms of thickness, that actually is fairly obvious on the scan, particularly if you compare it to the contralateral side. So if
Mhm.
you use an asymptomatic side or an asymptomatic teammate as a reference, you'll see that the tendon has kind of a gradual, like it does get thicker as you get more proximal, but like it's a gradual. In patellar tendinopathy, it's like pretty consistent, and then there's just a huge but notable bump
Mhm.
out where the tendon appears. A lot of these things come in conjunction with each other too. So you might see thickening around hypoechoic tissue. So
Mhm.
there's like a
Okay.
couple things you can look for in the same region of the scan.
Great. Yeah, all my tendinopathies I look at under imaging.
Awesome. That's
Yeah,
great. Yeah.
and I don't have great thresholds. I'm comparing to other side and
Hmm.
trying to make them more symmetrical. But with
Yeah.
loading, we usually see them become more symmetrical for sure.
So much of it is like setting dependent. So we
Hmm.
have spent so much time just playing around with the gain and the depth and when to adjust it and when to not. I mean, thankfully the patellar tendon is very superficial, so usually the
Hmm.
depth isn't a huge concern, but you can get
Hmm.
some pretty wild variations in your assessment of hypoechoic tissue based on the brightness and the gain and some other things. So
Even just heel toeing the probe
totally,
makes a big
totally.
difference.
Yeah. Yeah, yeah.
Molly, do you have a question?
Yeah, the chat was disabled, so can you hear
Oh
me?
no, I'll try to people on raise your hand if you
And
have
here we
questions.
thought we had no
I was
questions.
like, why aren't there any questions? There's got to be questions.
Oh,
Can you
shoot.
hear
Thanks for
me?
the heads up, Molly.
Okay. Megan, so obviously like they're gonna run asymmetrical when you're first getting them to run after ACLR. But how like long will you let them kind of go like that before I guess you need to probably get concerned or tweak things?
Yeah, that's a good question. I'm usually looking at pain and swelling
Okay.
as my metric of it's too difficult. Um, and then it also kind of depends on the athlete and what their goals are. If their running looks absolutely horrendous and they have no goals to get back to running, that may be a person that I do a lot less with. If
Hmm.
it's somebody who is an athlete who's going to have a lot of running in their sport, or, we've had people who are actually runners who come in. If I see that they are starting to develop these persistent gait deviations, even once all of those other check boxes have, their strength is good, they're not swelling, then that may be somebody that I take a step back with and try to dig a little bit deeper and do some of that additional plyometric work or actual different types of specific running gait interventions like cadence manipulation with. But I'd probably give them a bit, a few months,
Yeah.
and only intervene if it looks pretty bad.
Thank you.
Mhm.
That was a great question, Molly. Well, while we're waiting for to see if there's any other questions, I just want to plug two more Running Sig sponsored
Kat has a
events that are
question.
coming up.
Sorry.
Oh, where was it? Cat.
Hi, can you hear me?
Yeah.
Yes. Megan, I have a question about the intentional stiffness that you talked about with your plyos.
Hmm.
Could you tell us a little bit about how you implement that, what cues you're giving, and dosing for that? Like how long would you, I don't know, want them to work on that?
Yeah. So once I see that they're able to land with it bent, like we're getting them to land and go through a lot of knee excursion, and they do that in both those segmented and in where we're adding in the landing plus the exploding, and they're really comfortable kind of bending into the knee, then we'll start to do more time limited. So I would cue them to try to get off the ground as fast as possible. And when you start to cue things like that, the knee is not going to go through as much excursion. So it's in the cueing of how quickly you want them to get off of the ground or reverse out of that position. We are lucky enough to have force plates, so we can use things like reactive strength index to get metrics of how quickly they're able to reverse out of that. But it's really just the addition of that speed component and trying to get them now to be able to use the quad more rapidly, as opposed to initially they're landing with a stiff knee because their quad can't absorb load. But once the quad is active and strong and able to control the knee, we want it to be controlled in a more athletically advantageous manner, which is that quick, kind of rapid movement from flexion into extension. I don't have specifics on how to do that. It's going to look very different for everybody. And typically, when they're in that phase of rehab, they're going to be pretty integrated back into sport. So I think having a strength and conditioning coach or somebody who's really knowledgeable in that type of progression help you with that.
Cool. Thank you. So
Hmm.
just to clarify, you're not
Yeah.
they're not landing with this Disney. This is for more like a drop vertical jump or something. Or like a, is that correct?
Yeah. 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 Like a drop vertical jump, like something where you're having to absorb and produce force quickly. So
Okay.
yeah, yes. I'm not
Okay.
asking them to only land with just a stiff knee. It's more that reverse into a jump, like a drop jump.
Cool. Thank you.
Hmm. Mark has a question.
Mikkel, I kind of had a question for you
Great.
about the patellar pain,
Hmm.
because obviously we want to like, and this is more specifically for like competitive, your more competitive athletes, but we want to kind of minimize the amount that they have to cut back on their mileage or their
Hmm.
training while
Hmm.
still giving them some relief from their symptoms. I'm curious if you guys have seen any kind of like if there's a percentage of volume that you bring it down or anything like that, any kind of reduction in training volume that allows you to, improve symptoms, but also it doesn't, have them lose fitness, if that makes sense.
Sure. I mean, it's so nuanced. So based on the literature, we don't have a set percentage of like drop to 70% of your pre-injury volume, and that should be enough to alleviate symptoms. I think considering some other tools to support at least the cardiovascular health, so that could be cross training via bike. If you're lucky enough to have like an Alter G or a boost treadmill and running with reduced body weight, that may certainly alleviate the knee symptoms while keeping your cardio high. Um, so just any cross training to keep cardio up. I think if you kind of or have an opportunity to get to a symptomatic athlete early enough, perhaps the volume reduction doesn't need to be so dramatic. So typically it's not like, oh, I just woke up one day and my patellar tendons are on fire, right? Like there may be some gradual symptom development that particularly gets worse after, 2-a-days or, sprint repeats during track season or something like that. And so if you can just try to do some of the early volume management when they start to get a little symptomatic, but it's not full blown, like really impacting their training, that may head it off. Um, but otherwise, it's tricky, it's nuanced. I think you could even consider like let's try dropping 10% or taking, a mile off of each run and see if that helps. If it helps, then that was probably enough load to enough volume to reduce. If it doesn't help, maybe scale it back further. But its tendons are a little bit slow in their response. And so I would probably prepare your athlete if they have bad tendinopathy. This could be a 6 to 8 week or longer reintroduction of load. For patellofemoral pain, some of the gait retraining metrics or some of the brace or not bracing, some of the like orthotics or patellar taping can provide fairly instant symptom relief where you might be able to keep the volume pretty high while you work on strengthening or gait retraining if appropriate.
Thank you.
Sure.
That was a great response, Mikkel. Also, the plug up past ASBT talk that we had with Eric Hegedus and Tom Goom on return running, there was a lot of contextual factors that were brought up in that talk. It's on YouTube, AASBT's YouTube. Just this last year was so many things to consider. Where are they in the season? Is something run through? Are they reacting to like the ISOs? Can just the ISO get them under control and not impact their training too much? But that was a. I wish we had a better guide on what that threshold could be, Mark. Any other questions out there right now? Well, I'm going to keep plugging those next two talks we have coming up from the running SIG. We have return to running in the perinatal athletes, screening, loading, and performance strategies with Lisa Piropato and Caitlin Jurgens. This is going to be a webinar on April 22nd, so look out for that one. That one's going to be fantastic. I think we're going to have a lot of big attendance there, big, important topic. And then Danny Trowell from Down Under from Australia. She's going to discuss effective concurrent strength and endurance training in runners with Jason Tuari from the running SIG. So look out for those two coming up in April. Thank you, Megan, Mikkel, Chris, and Dr. Katie Lucas from afar. We appreciate all you do for the ASBT.
Yeah.
Thanks for having
Thank
us.
you so much for having us.
See everybody.
Bye, guys.